Now we will talk about how to manage these complications of liver cirrhosis. First, we will start with a general approach to managing cirrhosis. Identify and eliminate the cause. If it is alcohol, avoid alcohol and plan for transplantation. If it is HCV, try to start HCV medication. To prevent the disease progression and the complications. Avoid hepatotoxic medications to prevent further damage to the liver cells. Assess, diagnose, and treat complications of decompensated cirrhosis appropriately. Liver transplantation is the only curative treatment modality for decompensated cirrhosis. We will start with variceal hemorrhage. How to manage the variceal hemorrhage? Like we said, varices is dilated veins in the esophagus, especially in the esophagus and stomach. And with these dilated veins, with any increased pressure, it start to rupture and start to bleed. The standard of care when the patient have variceal bleeding, we start with fluid resuscitation because patient has lost many or large volume of fluid or blood. And then endoscopic variceal band ligation. Band ligation like this image. If we have here any damage, we make band ligation to avoid this and to avoid this bleeding from this side and stop the bleeding and till further management. The other treatment that can help is somatostatin analog with like octreotide, and octreotide can make some vasoconstriction, so the vessels is dilated and has with any pressure it can rupture, so we can use octreotide to vasoconstrict the vessels and decrease the bleeding because the blood supply to this area decrease and stop the bleeding. We should give prophylactic antibiotics because variceal bleeding is associated with spontaneous bacterial peritonitis. To prevent spontaneous bacterial peritonitis, we should give prophylactic antibiotic like fluoroquinolone or ceftriaxone. And after we manage the acute event of variceal hemorrhage, we can give secondary prophylaxis with a combination of endoscopic variceal band ligation and non-selective beta blocker. For hepatic encephalopathy, the main cause, like we said, is urea. How to manage this? To get rid of extra urea in the GIT by lactulose. Lactulose has two mechanisms. It is laxative, and the other mechanism is it is catabolized by the bacteria flora to lactic acid, and lactic acid with acetic acid can convert the ammonia from the unionized form to ionized non-absorbable ammonium, and this reduce the plasma ammonia concentration. The ammonium which is ionized non-absorbable, so it will not reach the blood flow. Also, with hepatic encephalopathy, we can decrease ammonia by killing the sum of normal flora. If no improvement with lactulose in 24 to 48 hours, we can add metronidazole or rivaroxaban. Antibiotics cause alteration in gut flora leading to decreased production of ammonia. For ascites is accumulation of body of fluids in the peritoneal space. To decrease this edema or ascites, we should advise the patient to make sodium restriction and give diuretics. It is extra fluid or over fluid, we can give diuretics. Combination with loop diuretic furosemide and potassium sparing diuretic spironolactone. This combination is preferred to maintain potassium level normal, because if we used furosemide alone it will decrease potassium, and if we use spironolactone alone will increase potassium. So combination will maintain the potassium level in normal. If tense ascites, if the patient has severe ascites and very tender, we can use something is paracentesis. Paracentesis is if this is the abdomen, by needle we extract some, we take some fluid from the abdomen to release the abdomen and decrease the pressure inside the abdomen. If you make paracentesis, we should administer albumin at a dose of 6 to 8 grams per liter of acetic fluid. If you, for example, extract 5 liters, so for each liter you give 6 to 8 grams of albumin to compensate for this fluid that is extracted. For spontaneous bacterial peritonitis, the bacteria is usually enteric gram-negative bacteria. As we said, this is normal flora, the enteric gram-negative that lives in the intestine and start to translocate and infect the acetic fluid. So the antibiotic of choice, we need gram-negative coverage with third generation cephalosporin like cefotaxime or ceftriaxone. All patients recovering from initial episode of spontaneous bacterial peritonitis should be treated indefinitely forever for their life with oral prophylactic antibiotic with norfloxacin or trimethoprim sulfamethoxazole combination. So it is secondary prophylaxis. Secondary prophylaxis after the first episode of spontaneous bacterial peritonitis. So we made a quick overview on liver diseases. I hope this help you in your exam, and see you soon.